Welcome to the Functional Code, your go-to source for decoding optimal health. Join Dr. Addy and Dr. Jace as they break down the science behind pain, performance, longevity, and more, making complex concepts easy for you to understand and apply in your life. Your journey to a healthier you begins with understanding the Functional Code.
Disclaimer: the content provided in this health podcast is for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Reliance on any information provided in this podcast is solely at your own risk. The creators and hosts of this podcast are not responsible for any actions or decisions you may take based on the information presented.
Welcome back to the Functional Code. We're going to be going over elbows, wrists, hands, ankles, feet. We're going to do the deep dive on the extremities today. I'm Dr. Jace.
I'm Dr. Addy, and thank you guys so much for continuing to support and watch us. Today we got a really great podcast. We're going to be diving into the hands, feet, wrists, ankles. We have a lot of info coming at you today. Really, what we're going to be talking about first and foremost, like always, Doc is going to do a phenomenal job of explaining the evolutionary change of how we've developed these strong hands and feet, what we used them for back in the day versus now. We're going to be jumping into the common conditions of the elbow, the wrist, the ankle, the foot, things that I know many of you have heard of. We're going to be talking about carpal tunnel syndrome. We're going to be talking about golfer's elbow. We're going to be talking about tennis elbow, Achilles tendonitis. We're going to be talking about bunions and other types of feet and ankle pain. We're going to break down each of those, finishing off with Plantars Fasciitis, which is, I know, another big one that people struggle with. Lastly, we're going to be talking about tools that you can use to take care of these issues yourself or at least manage them. So, Doc, jumping in today, we got evolution of how we developed these strong hands and feet. What do the people need to know about where we came from as far as the digits and the differences back in the day versus what we have now?
Yes, so when you look at fossils of human remains, especially ones back 2 million years ago from a species known as Australopithecus. I actually figured out how to say that word today, so that was good. Now, when we look at the bone structure, there's a lot of research on the tension being pulled off of certain bones, which gives us more insight on the ligaments, tendons, or the rough estimate thereof. And then we compare that to the normal chimpanzees, we compare that to normal monkeys, and then also to our structure. Now, the interesting part with that is the average height of those individuals back then was like 4'5", 4'6", give or take. So it's definitely a much shorter specimen. But looking specifically at the elbows, the hands, and then I'll dive into the ankles, feet here in a second. They were naturally gifted and born with longer arms than us, a little bit more of a shorter torso. And then with the feet, if you could probably guess that they had a much wider stance, especially between the first digit of your big toe out from the body. But starting with the hands, and a lot of this is somewhat theorized because of the soft tissue. We weren't able to necessarily confirm for a fact of this interdigit space or the webbing. That was actually known as interdigital membrane, if you can think of it that way. This has been known to have those specimens find food in waters, in rivers to help catch fish food, and over time it wasn't favorable for adaptation, so that shrunk over time. But you can notice that some individuals of all humans have a little bit more web versus others. But the one huge distinction between us gripping and creating fine motor skills with the connection of the brain to the hands is that thumb going more off to the side and be able to move in a bunch of different ways. Thus will help us grip, thus will help us throw objects and then eat food and whatnot with that. And so that was a huge factor of just the hands itself. Now over time, the hands shrunk, the shoulder adapted, and we weren't needing the huge web if that was the case. And because of our fine motor skills, our hands strengthened, but it also forced the hands to shrink in size. So that is just something that over time we want to make sure we increase the connection between the hands and brain, thus for better motor and fine skills for our species long term. Now, how this affects you is just the knowledge of where we're at right now and where we were, and what sets us apart from other species. Now, going into the feet. The feet are interesting. So with the bottom of the foot, there's three main arches, which we're going to dive into a little bit more here in a little bit. But there's a medial arch, there's a lateral arch, or lateral longitudinal, medial longitudinal, and transverse. Now, the species back then, based on the bone structure, is that big toe had that first digit more out wider, and thus allowed for us to move and navigate the planes. It also allowed for more of a flexible midfoot, thus so if we step on any rocks, we're able to give instead of have tension or sharp pain on the muscles on the bottom of the foot. And we also know from Australopithecus to some of the species of like the Homo sapiens or some of our recent ancestors, that the arch started to become a thing more around the time of Homo erectus, which was about, a million years or so ago. And that's when we started to create the medial arch. Thus, so when we stand up and move on two limbs via bipedalism, we're able to help for shock absorption of the body and also to help propel us forward and for longer periods of time. So it's almost like that medial arch is a spring to a certain extent. And that was another huge factor that got brought in from the foot as we stood upright. So those are some of the big main aspects between the hands, wrists, elbows, and the feet.
You ever seen a picture of those tribes people who never wore shoes?
Yes.
And what their feet look like compared to like what, people who wear shoes as feet? It's crazy how much more wide and strong and thick looking their toes are, and just the actual, my guess is the ability to use their toes is more as hands if they're climbing and running and grasping. And that question comes of, is that what our feet are supposed to look like?
Probably.
Right? And if they
extent,
don't, then why is, what kind of issues is that going to cause down the road? Which, again, a lot of the population have bunions and toe and feet pain. And is it because we're not stimulating our feet enough? Would it actually prevent arch collapse? Like all these things that you think about of, shoes, of course, are super helpful in certain instances, but should we be weight bearing without them? And should we be in nature, climbing, doing all those other things for proper foot health and progression?
Yes.
I don't know. It's kind of an interesting concept.
And I mean, when you look at the standpoint from like professional athletes and sprinters, I think we would then aim towards the side of having the arch versus a wider foot. But I don't know if that's ever going to be a thing that we might be able to test out, because when you go into those indigenous tribes, like especially the ones that are out there right now, they don't want to see any foreigners, so
Yeah, I know.
they'll end up killing anyone that comes
I remember
near.
when I last saw that picture, though, it blew me away because those feet, I had never seen anything like it. And it made me look at my feet, and I was like, oh, is that what mine's supposed to look like? The other thing I remember in anatomy lab was our teacher talking about how we have one tendon that, this is like one of the more recent changes of our evolution, and it was the loss of what's called, I think it's the palmaris longus tendon. And it was a tendon that was helpful in grasping and holding on to things, so like climbing trees. And some people still have it, some people don't. And so I think one of the ways that she had mentioned of checking if you have it is when you heavily grip and you kind of bring your wrist backwards. Most of you should have about 3 tendons in a row. And if you have the ability to see your tendons, you can count and see 3. But there will be some of you who have a 4th tendon, and I do.
That's crazy
And
cool.
I didn't realize that I have
Ooh.
the palmaris longus tendon still.
Hey, let's go. I mean,
And
shoot, I only have like 2.
yeah, so
That's crazy.
yeah, because you would have been able to see it on the lateral here, or on the the
I
lateral.
just got like a really weak one. Okay.
So what was interesting was we actually found a cadaver in my time that was there that had it still.
What?
And so I got to see it, and it was this tiniest little muscle belly, and then it was just this incredibly long tendon that just attached. And my guess, it over time probably got adapted to be a stabilizer when you held, and so it just became very white tissue based and as more of a stabilizer of holding and grasping.
Crazy.
But of course we aren't climbing trees and holding on and hanging from things for long periods of time, so we de-evolved without needing it. But I always thought that was super interesting when she had mentioned that. So Doc, we can get into the anatomy, physiology of the hand, the foot, the arch, and of course the legs. So without, of course, getting too deep into each of those, we'll try to do our best to jump into that within this podcast. But Doc, you just want to do a breakdown of each of those kind of muscle, bone, structure-wise?
Absolutely. So, and I'm not going to go in depth with each and every small muscle because there's a lot. Same thing with all the bones. I think just have a general gist of what our elbows, hands, wrists, feet are will give us a better understanding. So let's start upper extremity and work our way down. So between the forearm, there is an ulna and a radius, and that goes and helps with the connection to the humerus, thus creating the elbow. Now that goes down to carpal bones, which is 2 layers, and that helps for stabilizing the wrist. You'll also see with people that spend a lot of time at the computer that they're going to become flexor dominant, or where the muscles on the front of the forearm are going to be very tight. It could be stronger as well, but that also forces compensation and weakness on the backside. Now for some people, if you create your hand nice and straight, you might notice a couple different things. Either one of which, if you have your arm all the way out, you might notice that your forearm might deviate outwards, which that can create other problems, which we'll get here to in a sec. Or if you hold your arm straight, you're going to notice your wrist and your hand will go more inwards or towards the wrist flexors. Thus, another reason why other problems can come around in the wrist, especially on the front side, often due to carpal tunnel syndrome. Just knowing that is incredibly important. Now, there's 27 bones in the hand. With that, there's also about 35 muscles. Now, compare that to the bones of the feet, where there's 26 bones, but only 20 muscles. Now, I was thinking about this when I was going through this last night, more theorizing than anything else. The connection between the brain and hands for the dexterity and how we have evolved over time, and utilizing our hands as tools for survival and adapting the small fine muscles, kind of like what Doc said, that one muscle tendon that some people have, some people don't, and how we've adapted. I'm theorizing, okay, if there's an increased connection between the brain in that area, did that force the body to adapt to have the structure that we do? Or is it that the fact that because the feet only have about 20 muscles, is it the connection between the brain and the length of the nervous system down to the feet? Mm-hmm. Is that also why this hasn't adapted? Do we only need so many muscles to hold us upright, which is more than likely a factor? Now, as we go into the feet, like I said, there's 26 bones in the feet, but the one main thing I want us all to pay attention to is the arches of the feet. So like I said previously, we have a medial longitudinal arch, which runs on the inside of the foot, and that it holds the arch, which allows us for shock absorption, for propelling us as a spring moving forward, and then it forces the lateral longitudinal arch to force more of a stabilizing structure. Thus, a lot of the muscles of the feet also go and come from the calves. So when we look at treating and healing the feet, we have to look at knee down on how we go about the health of that. And then I want to end with the transverse arch, which if you look at back from, like I said, the ancestors and how they had a wider arch, our transverse arch became much thinner, which is why it's almost more important to allow grippy motions of the feet, which that's when certain areas of rehab come into play. That's also where you have to pay attention to what shoes you wear as well, which I do want to save that for the end because that is something that we want to dive into a little bit more. So looking at the ankles, feet, the calves and muscles going down between the forearm, between the hands and the small digits, we want to be able to utilize these structures, thus so we're not, one, in pain, but two, so we can maximize the efficiency of our everyday tasks.
Yeah. So what people don't realize is, as we've evolved, we have a certain arrangement of the brain tissue, and it's put in a certain way for certain reasons. So it's called the homunculus. And what the homunculus is if you were to take basically a side shot, cut straight down of your brain, and you looked at the areas that it correlates to, you'll find that the eyes is incredibly close to the hands. And what you'll notice is it's actually a lot bigger and closer to that area versus if you go certain ways down the brain, it'll get to other parts of the body. But the reason why you had your hands right next to the processing area of the eyes is exactly why we have what's called hand-eye coordination. Mm-hmm. And so if that area in any way is compromised, that's what can throw off hand-eye coordination, such as a injury to the brain. There are other things that also can predict longevity and health. That is with grip strength, making sure that we have a strong grip. Most humans, especially males, will have anywhere between 70 to 100 pounds. Females anywhere between 40 to 70 pounds. And then again, it's your ability to have good hand strength, which can then correlate to good hand-eye coordination, which is catching yourself, making sure that you're not falling. Those are just, over time, going to help you obviously avoid injury and have longevity. Other markers that they're showing or using for predictors of longevity is going to be toe flexion. The reason why toe flexion is so important is if we don't have toe flexion, that's going to actually reduce our ability to have ankle flexion as well. Over time, it's going to start moving up the chain as far as lack of motion. But with toe flexion comes our ability to have propulsion. And when we can propel ourselves, we can also catch ourselves and have good toe flexion strength. Mm-hmm. And there are times where I've found athletes who were some of the biggest athletes I've ever seen, and they weren't able to do an appropriate squat. They weren't able to, once they were down, and propel themselves back up with good toe flexion. They couldn't figure out why they had such disconnect in their squatting. And what we found was we went through the whole gamut. They couldn't figure out, these doctors couldn't figure out why this athlete was not squatting appropriately or why he had weakness. And we finally figured out it was because he had such weak toe flexion, and that was it. Mm-hmm. We were able to train toe flexion, like Doc said, actually trying to grip and improve toe flexion strength. We did that, and his squat went back to normal. Mm-hmm. And it's just these little intricacies that you don't realize have such a huge effect on your entire performance and well-being. Something as little as your tiny toe flexion strength, and it actually does play a huge, huge role in fall prevention and making sure that you have longevity moving forward. Lastly, fine motor skills and dexterity. Again, if you lift a lot of heavy things, you're already going to have great hand strength and dexterity. As far as fine motor skills, it's just making sure that you can appropriately, again, that's coming back to hand-eye coordination. So fine motor skills is just the ability to do things like put puzzles together, cut things, maybe even sew, those kinds of fine motor skills. Now, I'm not good at sewing, but I can assure you give me a good few minutes and I could probably loop the string through the needle. But if you start seeing a breakdown in your ability to have the fine motor skills, it's going to catch up to you, and eventually you're going to start missing little things, and it will make a difference. Ankle range of motion is also another key player in fall prevention and longevity as well. So it's really, what we're trying to say is, it may seem like these small areas of our body don't play a role with the rest of us as humans, but it absolutely does. And if we do not take care of those areas, which it's easy to forget about because they're the farthest away, it will start impacting your health. And feet is a huge one because the hands are closer to the heart than the feet are. And what you'll find is over time, feet are the hardest to continue to supply blood to. And they are also the first that usually break down because you don't walk on your hands. You walk on your feet. So making sure that you take care of your feet. And like Doc said, we're going to get to proper shoe wear. We're going to get to improving the health of them, making sure they're strong, what you can do yourself to make sure that you are keeping your feet where they need to be. Some of you don't even realize you're already prone to having poor foot health. And one of those is either diabetics. Another could be if you're just on your feet a lot. If you're like a concrete worker, construction worker, your feet are going to break down quicker than others. So those are just things that we want you to think about while we're going through this podcast. And if we hit on those topics, just take note of what we're saying, because it is going to make a huge difference in the length of your life and the quality of your life if you continue to take care of these little guys, for sure.
And I really like how you put like the homunculus, which Doc said a little bit ago was the connection the brain centers to the body parts and how much of real estate it has in the brain. He explained it incredibly well. And also obviously the connection outwards. It's such an important aspect that you have to think about for these tools that we have long term.
For sure.
Yeah, that's pretty good, man.
And so starting off, we're going to jump into the elbow. And we want to talk about some of the more common issues with the elbow. And I know a lot of you are already probably jumping to some of the things that you've either experienced or heard other people experience. But the first one is got to be tennis elbow. And lateral epicondylitis is the other name for it. And tennis elbow, from what I have read and over time, Doc, do you play tennis?
No.
I was going to say.
I wish.
I actually don't. I need to play. I haven't played pickleball yet. I have never played pickleball,
Dude,
but I know
we gotta do that.
that one's a lot of fun
I've done
too.
it a couple times,
But we're seeing a lot more people come in from pickleball injuries. It's crazy.
of all ages.
It's crazy.
all ages.
But with lateral epicondylitis, what people, from my experience and my research, what people need to get over is it may not be an inflammation issue. It's maybe more of a nerve issue. And so we'll get to that in a little bit. But Doc, do you just want to quickly jump onto tennis elbow, what people will experience from it, and what are the more than likely causes of why people are getting it?
So going back to the beginning of the podcast, when I said bring your arm all the way straight in front of you, if you notice your forearm comes off to the side like quite a bit upon your upper arm or your humerus, that is where that could be the start of potential risk for you having this lateral epicondylitis, or tennis elbow, if we will. That's where there's a lot of inflammation, tenderness, spasming of the lateral muscles and tissues in the outside portion of your elbow. And oftentimes that's due to overuse injuries. Thus why when they say tennis elbow, the backhand puts a lot of force in an object and your whole arm as a whipping motion all through that outside portion of the joint, and also those small tissues that aren't necessarily made and adapted to have a lot of strength. But that's where you have to look at, okay, observation, assessment. Does your forearm go outwards quite a bit when you straighten your arm? If so, there's a few things that we want you to work on in terms of lengthening out those tissues on the outside portion of the forearm. But yeah, and it can also have other symptoms of like burning tension. It could have a little bit of radiating pain going down the arm, but that's where majority of the time people are just going to notice pain, discomfort, irritation in the outside portion of the arm. And it also could be due to gripping motions over and over again. So we see this with male men, male women that are out there gripping and putting papers in slots over and over again for multiple times. That's
Truck
a huge
drivers
thing.
is one, constantly gripping that steering
Very
wheel.
good call.
Construction workers, anyone who is
Yes.
gripping things for long periods of time. And again, the idea is chronic overuse. And
Yes.
when you have already tissue that's hypertonic or just it's incredibly, it almost looks swollen, there's going to be a chance that it can push against certain structures. And the study I always come back to is over 63% of patients in this study had what was called radial tunnel syndrome. And that is just an area underneath the extensors that Doc was talking about. There's a nerve that runs through there, the superficial radial nerve, and it is compressed. And so patients that had lateral epicondylitis symptoms, 63% of them had radial tunnel syndrome. So in my experience, I find that if you are having those symptoms, the concept or thought of trying to alleviate and help this shouldn't necessarily be to reduce the inflammation, which if you did and it did help, I wouldn't disagree with that, wasn't the issue. But think of it as more of a compressive type symptom where getting rid of that tonicity or tightness is something that could alleviate the nerve issue. But just from the inflammatory component alone, it's easy to miss or alleviate the issues if you're just thinking that way, because what usually will happen is you go and get a cortisone injection and they think they're injecting the area. Even though that this may seem like a small area, there's a lot of real estate in this 6 to 8 inch area here. Anything from nerves to bone and joint area to even muscle and tissue. So, and I would argue that not every lateral epicondylitis case is the same.
Agreed.
And so one injection for all those different cases is where you're going to see a breakdown in symptom change. And we do. So Doc, I'll jump to my study first before we jump to yours. But
Perfect.
what you'll see is every study done on lateral epicondylitis involving injections is across the board. It's very difficult to reciprocate these studies of good quality injections. And what you'll find is this one that I have here, they took cortisone injections, they took Botox, they took autologous blood injections, they took PRP, they took saline, they took everything they could think of in this one study to try and reduce lateral epicondylitis. And what they found was in the shortest of short term, and when I mean short term, by 1 month only, I think the only one that was still left that had good results was Botox. And I don't mean good results, I just mean it still had some pain relief after 1 month. I think by either month 2 or 3, all of them still had back to normal pain. There was no alleviation anymore. And so in the short term, yes, there was, I think Botox led the charge as far as relief, but maybe for a month, if not 2. And by month 3, all of them had dropped off and patients were back in pain. So these are things that I think before you go and start asking for help, this is just something to note, where Doc is going to talk in a little bit here about how starting to break down the understanding of why you're having what you're having and rehabbing through it, making sure that you're starting to change the physiology and anatomy of that area because of what we can understand as either an entrapment syndrome or other underlying muscle tissue tension. That's where you're gonna, in my opinion, succeed in treating this issue. So Doc, I know you talk a lot about eccentric exercise.
Ooh, yes.
Of course, just PT alone. What did you find?
Yeah, so there's been a lot of studies with this, but going back to, excuse me, what Doc said with the injections and how each person can have different areas being affected, a lot of that will come back to either tissue targeting and how we want to go about the rehab process. But if you don't hit that specific area, when I thought about what you just said and what was going through my mind, I'm like, okay, well, if we don't get the specific area, that's going to be one thing. The second thing, the body will kind of reabsorb that fluid, whether it was Botox, PRP, steroids, all that will get reprocessed to a certain extent, like I said. But how you can treat this and give the tools long term, that's where the education comes in. So if this does come back, knowing what movements to go through, I think has a better approach. And this supports the study that I found in 2005 by Bissett et al. It's pretty much a study between mobilization / exercise and then manual muscle work and also exercise versus steroid injections. And they noticed way better of effect and way less pain with the long-term approach of going through eccentric exercises.
Nice.
So pretty much what that means is if you have this, unless you change the habits or unless you have the knowledge and tools to go into lengthening those tissues, you're not necessarily going to fix that problem. And what I mean by eccentrically, that's going from a short or contracted muscle to lengthening or into almost like a stretch. So with the muscles and tissues on the outside portion of your arm, and especially on the outside of the elbow, we want to look at not only the shoulder, wrist during the same movement. So you can either start with your palm coming up like a bicep curl, and then you want to slowly bring your arm across, bringing your wrist inwards, and having your shoulder come in closer to the body. Thus also, if you have, like I said, if your arm goes outwards, this will also help quite a bit to stretch out that area. Then over time, as this motion becomes easier, you can add a 2 to 5 to 10 pound weights to go from short to long and extend.
Nice.
It's pretty much short to long. That's pretty much the gist of this whole aspect. You can also bring bicep curl, kind of like a hammer curl where your thumb is facing your shoulder or your bicep, and you can do the same thing but pointing your pinky downwards and almost rolling your thumb forwards. If you are not watching this via video, I'm going pretty much a bicep curl, extending the arm, and then trying to bring my pinky down to the ground as everything's lengthened. So that'll help with everything on the outside, the tissue lengthening for the tissues of the wrist extensors on the outside portion.
Doc, how many
of the elbow.
times a day, roughly, would you recommend getting started on treatment?
I would do almost every single day, depending on soreness level, and you want to do that exercise until you feel a good muscle burn, not moving into sharp pain, but monitoring, is it very intense pain or is it just like an achy dull,
Yeah.
I know we're working these tissues. And that's where the movement becomes easier, you're going to have to add in either more intensity or more reps. So I don't like to say 3 sets of 10 because you can go through that all day long, but over time the tissues won't adapt. The body will compensate in various other ways. So paying attention to the muscle soreness and that you don't overdo it, especially earlier on. And with some of the other research articles of eccentric training, you usually don't want to start off with this right away. So if you have lateral epicondylitis, you probably first want to go to stretching with light isometrics or going to the lengthening and trying to squeeze the muscles in your arm first for maybe 5 to 10 seconds, relax, and go back and forth with that. Give it a few days and then go into lengthening and then go into adding weight with that.
Nice. And that's, it seems simple enough, right? It seems like, is this really what's going to take care of this pain I've been having for months? But what you'll find is, give it some time and it will. And what you'll also find is this is a really stubborn condition. And either, if you also feel like you need some relief in the short term, bracing is really helpful. What you'll find is if it's an overuse injury, putting and pinning this tissue down, it will shift the force to the healthier tissue down the forearm. And so when you pin here, you're going to be using more of the tissue that's away from the epicondyle. And if that area is where it's inflamed, if we can actually create the point of use going to be instead of here down here, that's what this brace will help you do. You might find that you actually get a bit of relief doing that, and that way you can at least continue with your activities. But brace is not a fix, right? It's just something that at least can reduce the pain for you without actually, needing medication. But you'll still need to make sure that you're properly training that area so that it can be normal again.
And I like what Doc brought up there. We had a patient came in, we found out via MRI tore some of the tissues in the outside portion of his elbow. Doc had a really good point to brace the area, which, like he said, forced more tissues farther away or down the arm to take on some of the stress and load, which accelerated the healing aspect. So it's, like he said, it's not necessarily going to fix the problem, but it will help in the rehab process significantly.
For
so,
sure.
yeah.
Okay. So moving on to the other side of the elbow, the medial is called golfer's elbow. And there is a couple things that can exacerbate golfer's elbow. The first is going to be this area underneath the ulna, which is the bigger bone here in the body. And what you'll notice is there's almost a crevice that you can find right underneath. It's kind of like a little groove. And in that groove actually runs a nerve, and that is called the cubital tunnel. And when you have a lot of strain in this area,
The funny bone.
yeah, the funny bone,
Yes.
that nerve can be hit, damaged, pulled, pinched, and it will send a lot of signaling, numbness, tingling down to usually these last two fingers. And so that is when you hit this area, and you'll notice that happen is the funny bone. It's just exactly that. That is what's happening during this time. But with golfer's elbow, there's a lot of torque coming through. Usually, if you're swinging left or you're swinging right, it doesn't matter. Most of the time, it's actually due to over gripping too. It can definitely be played with. It can definitely be exacerbated by playing too much, gripping too hard. So I'm not going to get into the specifics of the golf swing, but you'll notice very right away if you ever take a golf lesson is they say the grip is the first thing that you need to practice, because it will drastically improve your length of play and your ability to play for a lot longer if you have a better grip. Because over time, if you are over gripping, you'll notice by halfway through your round, your forearms will be on fire if you don't properly grip that club. And baseball players are, by and large, the biggest, I would say, repeat offenders of this, because they're used to gripping that bat so much. And in the golf swing, you don't necessarily need that entire grip strength. But back to the elbow. So with this area, golfer's elbow can have damage or compression to this nerve. You might even have ulnar collateral ligament damage just from torque in this area as well. So you might notice that can be impacting. And then just the tissues around this area, just like lateral epicondylitis, you'll have overuse, hypertonicity, tense tissues, inflammation that can be contributing to this area as well. So really what is tricky about medial epicondylitis or cubital tunnel syndrome, depending on how much of it you have, in regards to the research, there actually is good research showing that release of this area surgically can be better over a long-term period versus just PT.
Cool.
And I think what that really means is, and I haven't really figured out the surgical research to the extent that I'd like, but what I'm finding is there's so much impact on this cubital tunnel where this nerve runs versus lateral epicondylitis. Other than the superficial nerve, which is a very small nerve compared to the ulnar nerve, it has less of an effect neurologically versus here there is so much at play. So I think the release does such a great job to improve the ulnar nerve flow and communication that's why it can improve outcomes better than just PT alone. But not to say you still can't do proper nerve flossing. You can take a lot of that tissue tightness away. You can reduce inflammation. These are all things you can still absolutely do. It's just there are times where I think that tunnel becomes so enclosed and compacted where that release is the only thing that's going to help you. So the study that I have shows Mishra et al. PRP study on golfer's elbow found moderate evidence to improve pain and to improve function over time. It's just a matter of, is the collapse to that area significant enough to It's where non-surgical outcomes can actually improve that area. If not, I think a release is a pretty non-invasive. It's invasive, but it's not invasive enough to really cause too much over time, as long as they don't fully snip the nerve when they're going in and releasing. That's the other thing. You'll have patients where they have such bad hand pain where they'll actually go in and sever the nerve. Now, that's not what I'm saying you need to go and do. Now, there's a difference. Patients who have so much pain that they go in and get a ulnar nerve sever, that's not what I'm saying you do. But this is just a release. This is where they go in and arthroscopically debride the area and try to improve that tunnel flow. So
that's so cool. Yeah, and it makes a lot of sense too, because like there's certain injuries, especially with baseball players, or any time you are moving an object with your arms closer together and you're going from one side of the body to the other, it's forcing so much torque either on the inside or outside portion of the elbow. I had a study going back to the bracing between PT, muscle work, and exercise, and it showed way more improvement and less pain via just exercise and movement. But like Doc said, if it gets to a certain point to where that pressure can't be relieved, then let's go with the arthroscopic way. Because, I mean, it's hard to get that under control, especially if this is like professional baseball players, tennis, golfers. That's where, like, if you're relying on this part of your body for your life, you have to get this under control. The monitoring and maintenance long-term is going to be even more important.
Which is why so many undergo Tommy John surgery and other types of surgeries when that area of the body is impacted. It's a different injury, but same area. And again, it's just anytime professionals or just fanatics understand what happens when a pitcher goes through Tommy John surgery, they know why it needed to be done, because their performance long term will never be the same without undergoing that. And it might not be the same after undergoing it, but without it, there's a good chance that they might not even be able to perform how they could have if not doing something to alleviate the damage that was done to that area.
And just to go on that point, because I know Doc brought up Tommy John surgery, especially with younger pitchers playing baseball, trying to learn the curveball earlier on in your career, like I'm talking like anywhere from like 5, 8 years old to even 14 years old, if you keep going over on top and then forcing
that whip,
that whip, that is putting so much pressure and tension, especially as the body's maturing and growing. It can maladapt some of the tissues, bone structures of the ulna, thus lead to problems down the road. But it also has really good positive effects via Tommy John. But if that is you, if you're a younger pitcher, I'd switch up the repertoire, either one of which use the curveball minimally, unless you have to. Obviously, you have to practice it to get the release point down, but maybe rely on other pitches of either like the two-seam splitter, others that don't have that whipping formation. It's risk versus reward, right? Like if you're gonna go at that route, if you notice that you're naturally gifted release point to have your curveball go and break down, maybe it's for you, but it's something that you have to know the risks that can come about it. That just tells us way more rehab that, like I said, that has to go into either before or after pitching.
Just learn the knuckleball. Just learn the knuckleball. Everybody wants that, but no,
Cool.
that makes absolute sense. So that's the elbow in a nutshell. Those are the two or more common things that you're going to find with elbow conditions. We could have touched on some other ones, but in the comments, if you just have any other questions, let us know. We can try to touch on those either at a later date or just send you some info. So moving down to the wrist, if there's going to be one that we're going to talk about today, I think it's going to be carpal tunnel. We all know carpal tunnel syndrome, or at least should have an idea once you hear it of what carpal tunnel syndrome could be caused from, or at least you've heard of it before. And really what you'll notice in carpal tunnel syndrome is there are stages of it, and if it gets bad enough, it can actually cause long-term nerve issues and damage to the hands. And that's where surgical intervention is something that is needed. But before we get into carpal tunnel, Doctor, you just want to briefly touch on why patients get it and what anatomy is involved.
Yes. So with Carpal tunnel syndrome, that's where there's often pain on the front of the wrist. Oftentimes, if people are at a computer or their hands are rolled, or earlier I know we said truck drivers, there's so many professions that we find ourselves in, especially moving and working in front of us, to where if our fingers are placing downwards, that's where over time these tissues in this area can be compacted, and a lot of the nerves that go down from the arm to the fingertips, that can be compressed, thus create this pain, if we will. It can be sharp, it can be achy. To certain times it can be burning tension. It could also have burning tension on the outside portion of the wrist, inside portion of the wrist. You're also going to notice a lot of muscle contracture, spasming from the wrist flexors and some of the tissues on the inside portion of the elbow from the rolling inwards. Now, that's often where, if these nerves are compressed for a period of time, that's going to affect a lot of the carpal bones, or the 2 rows of the wrist bones, if we will. And then it's also going to force the pronator, which is pretty much a small muscle sheath which helps rolling of the wrist, in combination with the supinator, which is more closer to the elbow. Now, over time, these tendons, if they have the pressure on them, and when I say tendons, they're from the muscles of the forearms going down to the fingers. If they're compressed, that can also force those tendons and those sheaths that go to the fingertips to either sway inwards or outwards, which can also lead to trigger finger, which we're not going to go at that too much today, but that's where other conditions can come. It's pretty much contracture of those tissues on the front of the forearm, and with the carpal bones, there's a little bit of almost like a rounding tunnel, which allows the arteries, nerves, veins that go through, and if you're rounding your arm or your palm is facing downwards, that little tunnel becomes more flattened, and then that can lead to guarding spasm tension overlying it. It's probably the best way I could say it.
Yeah, and that little tunnel is called the carpal tunnel. That's why it's called carpal tunnel syndrome. And true carpal tunnel syndrome is where you have the actual carpal tunnel being impacted. Now there is another tunnel called the tunnel of Guillain that's just off to the side of it, which impacts more of the lateral fingers. There's also, like Doc was saying, and I love that you brought this up, there is also many other nerves that come down from the neck into the arm and the hands and the fingers. And where carpal tunnel can be a tricky diagnosis is there are, like I said, there's 2 different tunnels. We talked about the tunnel up here in the elbow. We talked about the nerves that run underneath the extensors, but we didn't talk about the nerves that come out of the neck, go under the brachial plexus in the axillary area here. There are plenty of areas that these nerves can be compacted, which can then cause radiating symptoms down the arm, even into the hands and the fingers. So it is crucial that you have a proper carpal tunnel diagnosis, because the first thing that if medication fails, the first thing that they're going to look to do is do a carpal tunnel surgery, and that's just they go in and they cut the nerve. I bet you that Doc and I can both attest how many times we had patients come in with that large surgery on their wrist, that big cut, and they said, I still have pain. And we know that, and it's because, again, this is a study that I found, up to 25% of carpal tunnel is misdiagnosed. It's not that it is done in a way that is either negligible or because they weren't, trying to help you, but it's because it's such a tricky diagnosis. And so you want to make sure that you have a practitioner who understands the differences between where these nerves go to, which fingers are actually in textbook carpal tunnel, which fingers are actually going to be affected, and what are the true textbook carpal tunnel symptoms as the stages go on. And so in the beginning stages, like Doc said, you're just going to have pain on the front side of the wrist here. But over time, you'll notice it's these 3 fingers that are actually going to be impacted. It's not going to be the outer 2. And so if you're coming into the clinic and you say, oh, I'm having carpal tunnel syndrome, and you put up these two fingers, I'm going to disagree with you, and I'm going to say any doctor that told you so is unfortunately needs to look at an anatomy book. It's these three right here that's affected. This is where the median nerve travels underneath the carpal tunnel into these three fingers. You might have tingling, you might have numbness. Over time, if it's truly compacted, that carpal tunnel, you'll actually develop atrophy of this muscle right here, these big muscles, and this is the thenar muscles, where, again, if you kind of put your hands up, you'll see that there's a kind of a hump, a rounding, but you'll find that that flattens over time, and you might actually even start seeing the impression of the bone underneath if it's that thin. And that atrophy, you absolutely do not want. It's difficult to bring that strength back into the hand when you've lost it, and over time, it can even cause permanent paralysis where you're not able to flex and use the hand how you should if the carpal tunnel compression has been there for a long time. So yes, that's where surgical intervention is absolutely needed if that's what's happening. But most of the time, and I'll go out on a limb and say this, it's coming from your neck. Mm-hmm. It's coming from your neck. Now, Doc did a great job of explaining how it is poor hand ergonomics that can cause change here. But most of the time, it's poor ergonomics of where your head is. And as chiropractors, we talk about that a lot. We talk about the forward head posture. We talk about how you're staring at a screen for many hours during the day. And that remodeling of the cervical spine can create such just poor output of communication via, I don't want to jump too much into it because we're just talking hands today, but basically what it causes is poor environment for those nerves to come out of, which is more often the case in my opinion, because what will happen is you'll find that patients who have had these drastic surgeries where they come in with these, and I'm telling you, if you haven't seen carpal tunnel, it is, they cut this right down here. I mean, it's super invasive. They go in and they sever that nerve. It is still present after they have it. They come in, we address the neck, we do therapy, manipulation, and that pain goes away. And now they're stuck with two great souvenirs from the surgery. And again, when you have that invasive surgery, you'll even find that they don't have the ability to flex and extend the wrist as well. And now they actually have, like Doc was saying, from those surgeries. So that's what I got to say on that.
Yeah, and there's different ways that you can go about it. I know there's a few studies out there, PT, that'll show improvements of symptoms, but I love how Doc said, you have to look at the whole body as a whole, especially from neck, of how the nerves go all the way down, and even the muscles from the forearms going down as well. So if you do have this, if you are looking at possibly going the surgical route, I would start with conservative care first for a few months, kind of like we said with many other conditions throughout the body, working on releasing the muscle tension on the forearms, especially the front side wrist flexors. Pay attention to how your hand and your arm placement are aligned. So is your forearm moving backwards upon your hand, or is your hand moving forward on top of your wrist, like excessively? Over time, you want to slowly lengthen those tissues, stretch by having the palm of your hand into a table, chair, and spend some time here over time with gripping of the ground or the surface that you're on. Adding that on for a period of time. I know trigger point therapy can help. I know stretching with muscle contractions can help. I would start with a bout of that for, like I said, a few months, and then see does symptoms persist. If not, we can possibly look at other interventions from there. But there are other ways that you can go about getting this condition under control. And it might have to be if, like, you're a desk worker, if you have no other way to survive and create a living with your palms facing downwards on, like, the computer, keyboard, truck driver, what have you with that, you're gonna have to take breaks throughout the day, whether it's setting an alarm on your phone and going to periods of stretching for a couple minutes, then going back. You're gonna have to probably do heat, ice, or a combination of the two, and it's just gonna take longer because it's more of an uphill battle. But look at your structure long term. Like, these muscles, these structural tissues, they are able to adapt, but it takes time, effort, and consistency.
Yeah. And I like that you said that of if this is your livelihood, you're going to want to make sure that you do everything you can to take care of this area. And surgery, as invasive as it is already going to put you back. The last thing I forgot to mention was splinting or bracing can actually be helpful if you don't want to go the surgical route. And that's the one where you can actually have certain braces that allow you to have finger use still if you want to brace and work.
Yes.
Maybe it'll help you more properly align that wrist, like you said, so it isn't more forward or backward facing.
And I know, Doc, just having a wrist brace when you sleep.
Yeah.
Because it's better use of your time. So if you're not mentally awake, if you're not going to be using these tissues, yes, the awareness factor of when you're awake has a different signal to the tissues of the whole body, but especially for the forearms in this sake. If you're able to brace against gravity over time, that'll help significantly. Even if when you sleep, if your wrists curl up, that will also lead to more of these symptoms and problems coming down the road. So by having that brace, it's not going to force you to curl your wrists. It's going to keep it nice and straight, thus less pressure on that tunnel. So yeah.
Beautiful. Yes.
Cool.
So that is the elbow and the wrist. Anything else you guys have for us, please let us know in the comments. We can address that. But we kind of wanted to just hit the more common ones that I think we have patients and people deal with. But jumping down into the ankle and the foot now. Ooh. We're going to hit on a big one. I know that this is going to be one that most people have either heard of or dealt with. Plantars Fasciitis. Now, before we jump into Plantars Fasciitis, I think there's a little bit of confusion between Plantars Fasciosis and Plantars Fasciitis. And we've talked about tendinosis versus tendonitis. And I just want to hit on that because there is a difference between the two. And it's just helpful to understand concepts while you're trying to help yourself. Because if you have a different idea of what's going on, it might actually sway you from making a certain choice of how to, or what kind of treatment you want. So
Good point.
Plantars fasciosis is just a degenerative change to the tendon in the area. Plantars fasciitis is now an inflammatory component with that. And you'll also find that over time, if there's a lot of tendinosis, where there's a breakdown to that tissue, that is going to predispose it to tearing. And when you tear your plantars fascia, that's very painful. And there's going to be times where you might not have relief of pain for up to 6 months to a year, even over a year. It also can directly correlate to the Achilles heel and its changes there, and whether or not you have pain. So taking care of this area, super important. It ties into the arch, like Doc has talked about at the beginning of the podcast. Just the all-around proper health of the foot. This thick tendinous area, which is called fascia, but it does tie into a lot of the tendons that are in the area as well. But the thickened portion of the fascia, what you'll have is the Achilles comes down, goes over the calcaneus here, and what you'll find is this thick banded tissue is the plantars fascia, and then it goes and webs into the feet. And the common point or apex of force on the foot is usually right at the middle, maybe a little bit towards the heel bottom area, and that's because as we walk, as you compress the foot out, most of the torque on that tissue gets put into that thick band, and that's where the fascia is. Now over time, if you are either pronated or you have flatter feet, where there's more, you're now predisposed to having more torque on that area, or again, you just don't take proper care of your feet, you're not wearing proper footwear to absorb the shock, it's just going to cause, again, more torque to this area. Now, there are a lot of things that can predispose you to having plantars fasciitis, and I want to make sure that I talk on that today. Reduced ankle dorsiflexion, so your ability to actually dorsiflex the foot is going to be crucial, because if you do not have the ability to change ankle range of motion as you're walking, it's going to put way more force and impact on the bottom of the foot. Basically, think of it like this. When you can dorsiflex and have heel contact and then actually roll through and use what's called the windlass effect, where you want to start on the heel and you want to end on the big toe, it creates proper force distribution through that foot. But if you don't, it's going to be more of a impact right on the bottom of the foot. You like that?
That was good.
And so, number one, the reason why I brought up ankle dorsiflexion in the beginning was, again, it plays so much into a lot of things, and this is going to be one of them. So we want to make sure we have good ankle range of motion. Number two, obesity, more weight causing more force onto this area. I don't think I need to talk too much on that. Work-related weight-bearing activity. Again, this is where we talk about if you're working on concrete or if there is an external force that is harder as you impact versus walking on grass or walking on turf, something that's not as heavy.
For longer periods of time.
Yeah, for longer periods of time. Teachers too, schools have that heavy linoleum, probably concrete underneath.
Yep.
I know teachers can get this a lot too. But think of it like that. Think of it, am I in an environment every day that is either needing me to have proper footwear to be on it? And again, teachers, and especially if you're female, I'm not saying if you're a male you want to wear heels, that's fine, but most heel wearers are female. And again, it's not a great way to support the foot. And if you're on your feet all day on concrete in heels, that's going to be a whole nother issue. But again, that's why proper footwear is going to be super necessary for this. Lastly, posterior tibialis weakness. It's just a muscle that over time, research and experience, I've found once that starts to weaken, you will see a greater impact of force being put on the plantars fascia. And what the posterior tibialis does is it wraps around the outside, it comes and it helps to actually lift up the arch. And so when you have good posterior tib strength, it can be an anchor point if it's strong. Strong anchor to keep that arch elevated. But if it's weak, that arch now has the ability to collapse at a more drastic angle. And so when you're putting force down and that arch keeps coming down and plopping all your force onto this plantars fascia, you're now predisposed to have tearing or tendon overuse causing inflammation, which then causes plantars fascia.
That's beautiful.
Fun stuff, right?
That's beautiful.
So plantars fascia, doc, what have you found in patients with plantars fascia, maybe patterns that they are doing in their daily life, and or what are some of the things that they kind of present with?
Yeah, so I'll start with a few things, but then I think we should both dive into footwear with this one, because as you're going through some of those topics, I'm like, okay, we absolutely need to address this. But usually, much like Doc said, it's usually a flatter foot. Oftentimes with flatter feet can become a lot of pressure and tension on the medial arch. And if you don't have that medial arch or the arch on the inside portion of your foot for shock absorption, for springiness to propel us moving forward as we walking around or as we're standing upright to hold all the gravity of our body down upon the earth. And especially if the bottom floor doesn't have the give to it, much the same as if we were to walking on like grass or something with a surface with a little bit of give, it's going to force way more pressure and tension over time into the ligaments, tendons, and muscle structure of the layers of the bottom of the feet. And with the plantar fascia, there's different muscles that are deeper or on the midfoot or in your middle foot. And when you look at plantar fasciitis, it's inflammation and/or compensation of the area. So when I say layers of this plantar fascia, there's a small, thick layer, and then there's layers that go overlying it. The ones that are going overlying it, which are closer to the ground, that's where a lot of the muscles, tendons come from the calf downwards. So that's where we're going to get into a few things longevity-wise on how we can maintain the structure. A lot of it will be via gripping. A lot of it will go back to our ancestral ways to try and create opening of the feet. And I think this is actually a good segue as we go into this. If you notice your feet are closer together or compacted, if we will, look at your shoes. That's going to be one area. Are they thinner or are they wider? For most humans, wider feet or wider shoes, will have a better effect long term. If you go and try on a pair of shoes that you're possibly interested in and want to go this path, you might find that your feet might move a little bit more. Okay, well, maybe if you want to hold off and wait, or buy the shoes and then work in those for periods of time, but just don't live in those or wear those every single day, and then go at Rehab to open up the feet. We have in office what's called toe separators. So if any one of you guys have had your nails done before, you might notice that there's like spacers in between just so the nails can dry. And I think we can get into this more with the bunions coming up here in a second, but as we're creating more time and pressure against gravity, as those toe spacers are in between your toes, your digits, it forces more weight distribution on the tissues on the inside, outside, and of the deep arch, which will then help redistribute pressure from a fine point to more laterally and more disperse that load, just so you're not putting all that pressure into one small area. Doc did a really good job on the windlass, was it windlass?
Yeah, the windlass effect.
Windlass effect. We learned half this stuff in grad school, but to have an understanding of proper gait mechanics, because we have to work with the structure we have. Like, we can work towards adapting to a wider foot, or kind of like how our ancestors were, but there's certain limitations we have with that. And then also, if you're an Olympian sprinter, you're not going to necessarily want a wider foot. You're going to want a foot kind of in the mid-range, not between like the feet are collapsed and compacted together, but probably a mixture between compacted together and then spread apart, just so you can have that springiness of when the heel or toes go down to the ground. It's that quick reaction to have that spring to get the foot back up in combination with the knee. So like when you look back at plantar fasciitis, or fasciitis if we will, if you notice your foot's pronating or creating a flatter foot, you're often going to notice a lot of symptoms on the inside portion of the knee.
Yeah.
Females especially, and with females naturally having wider hips just for the purpose of giving birth, it creates more of a Q angle, which is the angle between the pelvis, hip if we will, and to the inside portion of the knee.
Yeah.
So the bigger the Q angle, the wider the hips, the more in the knees are going, and that often comes with rounding or pronation of the foot. So when you're looking at treating this, when you're looking at providers, and if you have these problems coming up, you have to look at the whole body as a whole. You have to look at either strengthening and rehab of tissues on the inside, outside of the thigh, inside, outside, front, back of the calf. Also pay attention to the hamstrings as well. That's a whole thing itself, in combination to the rehab of the foot. So in order to get this under control, you have to work on the whole chain up, because of the factors that can be involved with this. But now going to feet and foot, this is where a lot of people are probably going to hate us saying this, because it's going against how you feel, it's going against the comfort level. When you have thicker soles, it doesn't allow contact of the ground,
Yep.
which just even on that standpoint, I think all of us should be out on the grass with our bare feet to have the communication and the electromagnetic effect of picking up that from the soil in combination to our whole body. We'll get to that in a whole later date, but the thicker soles of any shoes, yes, it can help for runners for that spring shockness, which will also aid for the medial arch. But if you are on that for a period of time, that will lead to your feet and the muscles and the structures of your foot to compensate and almost be accustomed to, or we're going to have to rely on
Yes.
the shoes instead of our structure.
Yes.
And thus why over time the feet will break down, the whole structure will break down. If you're having pain on the bottom of your feet or your ankle, foot, you want to walk on more firmer ground for periods of time, or do rehab to strengthen the arch and not rely on the shoes per se. So when you're looking at shoes, you have to keep that in as a huge awareness factor. Is it going to benefit you? Are you on your feet all day? Or is this just something that you're comfortable with? If it's comfortable, that's awesome, but know that if you rely on this, if you wear those shoes every single day, and shoes can be spendy, especially if you don't want to spend your money on that and get multiple other pairs of shoes, you have to pay attention. A shoe that has mold, a bendability to it, thus so it can almost work in unison with your feet. Gosh, was like barefoot shoes are a really good one that you can work towards. I probably wouldn't say go straight into them, but if you want to, if you have the availability to purchase those and wear them for periods of time, that will drastically improve your foot. There's also other shoes on Amazon that are a cheaper route. If you just type in barefoot shoes, there's a bunch of different brands and kinds that are constantly coming out. But Doc, I know we can dive into this for a while, but please give me your take on everything from there.
So when you're looking at shoes, the way that I would explain it to patients is you have shoes that have different consistencies of firmness throughout. Some of the shoes, and I know people aren't going to argue with me, but Nike is notorious for this. So what they do is they put a hardened, different consistency of foam at a certain part of the shoe, and then it's a lighter or firmer consistency towards a different or end part of the shoe. And why that's a problem is because it changes your gait. So when I look for shoes, I look for shoes that have the same consistency of foam throughout the entire shoe.
Oh, good point.
And if you don't have that, then that is, well, if you don't have that, then I'm arguing with you. Don't do that. As simple as that. And here's why. So when it's super hard or firm, that now changes or casts or blocks your gait. You don't have the ability to create proper distribution of the windlass effect, and it now blocks that heel contact to toe contact with the harder, firmer foam. Versus if it's all the same consistency, and like Doc said, definitely more bendable is the shoe that you should go for, because the more versatile and or movable that shoe, the greater adaptability it has to your foot and the better ability of you to actually not have a change in your gait. So that's where, when you're looking for a good shoe, that's the first thing that I look for. The second thing is, like Doc said, when you're running, there are certain shoes that they create which can help add to the way that you run and improve it, which is great. But a lot of you buy those shoes and then wear them all the time. And
that's the point.
And that is not what they're used for. They're used to aid you while you're training, and that's fine. In fact, that's probably helpful for a lot of you that get knee pain or need that help when you're putting that much stress on the foot. But now you take those shoes and you wear them over time, just day-to-day walking, and a lot of those runner shoes have kind of a rocker-looking type of foam, and it's that rocking that is, it's trying to mimic your gait. It's trying to actually do it for you. And what you'll find is it changes your gait significantly, and like Doc said, now you don't have the ability to adapt, and your feet's going to get weaker. You're probably going to have pain, and you don't have the ability to walk how you should. So in a nutshell, that's, before getting into the real specifics of it, that's kind of why you shouldn't use training shoes as normal everyday to day shoes. And if you're going to pick a good everyday shoe, make sure it's one that has the same consistency of foam throughout, and it's definitely versatile and adaptable. Some of the best ones that most people, not only that I've studied and seen as far as shoes go, but Brooks and Asics are usually the best when it comes to consistency of foam. And then any shoe that's gonna last you, you should be changing your shoe over a year anyway. But if you're trying to look for a shoe that's gonna last you longer than that, you're gonna buy ones that are gonna have that really, really hard foam. So you're already, in my opinion, not thinking of it the way that you should. So longevity of a shoe, there really isn't. Like, you don't want to go and think, okay, I need a shoe that's going to last me a good few years. It's like, no, that's already going into it wrong. Because those shoes that do last are the ones that are super hard, that change your gait, and that give you foot pain. So those are kind of the big three things that I want you to think about when you're purchasing shoes. Some of my favorite shoe brands are Allbirds. They have incredibly, incredibly consistent foam throughout. They're light, they're cheap. I buy like 5 of them a year, and again, they're just they're non-gait changing, and you can also switch out the inserts if you like. Yeah, I mean, I love Allbirds. Another brand that I like is On Brand. They have actually a cool, if you take a look at them from the side, they look like they have little squares going through all of them. And again, it's the same consistency across, and those little spacers in between the foam actually create a better adaptation when you're walking. Now, they're more of a running training shoe, so I only use them when I run and work out. But again, they do make shoes that are for everyday wearers as well. So we can go on and on about shoe brands. I'm sure we could even have an entire podcast on shoes alone. But those are the things that I want you to think about when you're purchasing shoes. And if you are having foot pain, look at your shoes. And I bet you one of the 3 things that I just told you might be hooked in there. Now, if you're using, let's say if you have, unfortunately, you have to wear boots during the day. Try to wear, I mean, Hoka is doing a good job of coming out with like a more industrial looking boot shoe, which does a decent job of not, adapting the gait. You can find some Red Wing in Minnesota. They do a pretty good, they have a really good boot. Again, it's expensive, but that thing will last you a good while, and it's one where, it's a high quality leather shoe. I don't want to get into boots though. Again, I'm kind of going down to a rabbit hole here.
To go into a few points of what Doc said, I absolutely love everything he said about that. You might have to go back and rewatch this section a few times, but an object or a thought that came into my mind as he was talking about this, and we get this question asked a lot, orthotics. Now, I don't want to spend too much time with this, but I think it's definitely crucial to go over this at this time. Orthotics, those are pretty much just devices or pieces of foam or different material that are placed on the bottom of the foot, thus the aid in your arches to help weight distribution. Now, when you look at this, they can be used as kind of like a brace. It's not going to necessarily help fix the problem, and if you wear the same orthotics for years on end, it's going to lead to maladaptation of your foot moving forward, especially if they are more firm, because back in the day, we're talking probably 10, 20 plus years ago, the orthotics, there wasn't too much literature research or applications on that area. And what we're finding right now, especially over the last 10 years, the orthotics that have a little bit more give to them have a way better effect. But I definitely don't want you to focus on wearing orthotics for the rest of your life. Like I said, it's much the same with the shoes. It forces you to rely on the orthotics and these things that you have to buy from products from the industry instead of actually building up your feet. So if you wear the orthotics, awesome, especially transitioning to more of a barefoot shoe. I love Vivio, shout out to them, please sponsor us. But no, going back to the orthotics, that's where to work towards strengthening your feet, which we're going to get to some stuff here in the later end of the podcast. If you strengthen your foot with the orthotics over time and you start noticing that, okay, I'm walking at home with no shoes on and it's not as painful, okay, awesome. Maybe we can not wear the orthotics as much or not for longer periods of time. So what I mean by that is if you are a teacher or if you're a construction worker on your feet all day long, maybe focusing on not wearing the orthotics on the days that you're not working, and then build up from there. And then maybe, okay, you did fine with that for a few weeks at a time. Okay, well, let's look to maybe not wear the orthotics on a lighter day or a day that you're finding that you're not staying on your feet for long, and then build up from there, and then try the transition out of the orthotics. I think that's a part that I don't think I've ever even heard of being brought up. It's, okay, I have orthotics, awesome. Or they start wearing, or I change shoes and I just forgot them. That's where people just stop wearing them, and it can either create problems or they can maintain. But it's knowing that the orthotics are a brace is something that, like, no human I would ever want, unless other conditions underlying, will wear a back brace and move around for years on end. Like, it's going to lead to wear and tear of the structure.
Maladaptation, weakness, it changes you. You get used to it. So, no, I like that you brought that up. And if you have an old cast plastic orthotic still from 10 years ago, please throw it away.
Please.
I had to tell so many patients to throw them away. And no, again, back in the day, literature was different, but now we've come to a point in time where we don't need to cast our foot. In fact, we never needed to cast our foot. Now, when you think about it, when there's pain and you brace it, the pain will go away. That's why the casts worked for the ways, for a certain time. But we weren't put on this earth to need bracing or casting. We were put on this earth to be as adaptive as possible, and we need to train that way.
Yes.
All right.
That's good.
Let's move on.
That was fun.
Lastly, we are going to talk about bunions. And for those of you who may know or may not know about bunions, a bunion is just a fancy word for a growth that can happen on the side of your first metatarsal. And it can actually start early on. You don't have to, when some people think about bunions, they think about maybe older people getting them. You absolutely can start, it can start early on. And so what happens with bunion formation is, number one, the first thing that usually happens is we lose the ability to have toe flexion. That's a good precursor to it. Other ways is just how we walk can change over time, and we just want to make sure that when we do walk, we don't pick up these patterns. And so the most common one is those of you who walk and they externally rotate their foot. Now, the external rotation is most commonly caused by lack of toe flexion. So what happens, again, we'll come back to the windlass effect. So the windlass effect is when you heel strike, you put the outer portion of the heel down onto the ground, you come through to the midfoot, and you put all your weight off on the toe and you propel yourself forward. Now, what happens is over time, when we lose the ability to toe flex, or we start having flatter feet, arches collapse, it's just harder for us to propel off of that big toe. We do this little mechanism to help it. Instead of heel contact down and propelling through, we heel contact down and we can't toe flex, so we externally rotate and we pivot off the first metatarsal. And that is the mechanism that starts to happen. So heel strike down, we can't toe flex, so we externally rotate, we come off the big toe. Now, for a day or two, that doesn't make much of a difference. Over time, you'll start to add a lot of force to this metatarsal. You'll see that your big toe will actually start to curve inwards or point inwards. And as you continue to pivot off of this tarsal, you will develop a large bunion or bump, and it can become incredibly painful. And what they end up doing is they break this toe and they surgically screw it so that it's straight again, and then they clean out the bunion. But now, oddly enough, what I just mentioned was lack of toe flexion is what causes this. When you screw that toe, you now cannot flex it at all. You cannot move that toe because it is screwed down. So guess how you're going to walk? You're going to walk the same way. That toe flexion is not going to happen, and now you're just going to walk on that newly surgically excised foot. So did it help the problem? No, it didn't help your problem. Yes, you got rid of your bump, but there's a good chance that bump might come back, or you're still going to have pain. And aesthetically, nobody wants a bump. I know that. I get that. But check and make sure this isn't happening right now so you can take care of it and even avoid surgery in the long run. So beautifully, Doc has talked about toe extension and spacing. This is a beautiful way to start taking care of this issue. And I'm only talking to myself because I know that I do this, and so I need to make sure that I'm doing it. But Doc, do you want to talk again on toe spacing and why it's so crucial in bunions?
Yeah, so I know we touched on this with the deep arches of the foot for plantar fasciitis, now going to the bunions. So, and there are individuals, and my wife is one, she has surgical screws in her first metatarsal, and it limits the extension. She can move quite a bit more, but For individuals that we have trained that don't want to get the screws taken out after everything's stabilized, which there is possibilities of that. Again, possibly not for everyone, but it is capable of how we can go about it. If you open up and create a wider base, that one again is going to help weight distribution going through the first metatarsal, first big toe, for propelling you moving forward. So it takes mental effort, it takes training.
Yep.
So what we ideally want to do is work into toe extension. So if you have the rod in your foot, you can still do this as well. You just have to you might have to monitor that feeling of, are things moving and does it hurt, like in this exact area of your toe. So you would want to go to toe extension, ideally up against either a wall or a tilted platform, and put light contraction of your toe down as everything's extended, and then try to bring your toe back up. Over time, work also in combination with the windlass effect, much like Doc said, heel to pushing off on your toe. So if you do want to get into exercising, ideally starting with walks, but it takes mental effort. Every step, focus on your feet, heel pushing off on the tip of the toe,
Yep.
heel, tip of the toe. You can also, probably more for advanced people that have tendencies already built up, backwards walking. Make the first contact on the big toe and then push off through the heel. It's going the complete opposite direction. Now, with the toe separators, when we're putting these in between the toes, moving, walking around, you're going to notice weird tension in other areas. Usually, how I give these out to people, you can buy them online. It's where it's like a plastic that's very moldable, that's can move around. It's kind of like a rubber band feel to it. I'd start wearing those about 10 minutes a day for the first few days. If you don't have soreness, you can progress to 30 minutes, stay about a week from there, and then you can progress to about an hour, a couple hours at a time, and that's walking, moving around, ideally barefoot, unless you have wider toed shoes and that you feel like the shoes aren't compressing, putting more stress on the inside of the joints, which is also important as well, because if you go running with toe separators on, even in wide shoes, that can create a lot of problems in the joints. So you want to work into this. So over time, you are definitely able to bring the bunions, whether it's surgically repaired or not, to bring your toes back to center. I know Doc brought this up previously. When the toe comes inwards, it's putting more pressure on the toes that are right next to it, and those can twist and rotate, and that will also affect the tips of the toes and your transverse arch as well. So that's also, again, going back to the toe separators, that will help all the other toes grip the ground and allow for propulsion moving forward. So that, and I know we have a bunch of studies we can go over here in a sec. PT rehab has a huge effect on the bunions, but if there's a lot of inflammation, if there's different types of arthritis, that will also affect the joints of the toes, also the hands. But that's where you want to monitor that, ideally with a medical practitioner, like steroid injections. If you do have them, they will only last for a period of time, because you're not going to affect the habits. You're going to still put more pressure through, much like Doc said, that first metatarsal joint, and you're not going to fix the problem long term. There are capabilities to get the bunion back to center, thus to help you ease up the pain, discomfort, moving forward from there.
And you know, it seems in the beginning of stages not an issue until how many years later, and now it is an issue. So first thing you can do is just take out your foot, start to see, is your big toe slanting towards your other toes?
Awareness.
That's already a first sign. You may not have the bunion, you may not have calluses. I have calluses on not my first metatarsal, but my distal toe joint. And so I've already found that I have my toe is over, and I already have calluses formed. So awareness. I am doing toe spacers. I'm practicing toe flexion. I make sure that when I walk, I am not externally rotating my foot. That's another Step of awareness, just look down at your feet when you're walking. Are you externally rotating your foot? And external just means out. Are you walking with your feet facing away from your body when you walk? Those 3 things. Toe in, do you have calluses forming, and are you walking with your feet out? Great starting ways for you to say, okay, am I going to be prone to developing this bunion? And when I tell you it sucks, like it is, it's super painful, and the surgery is annoying, and it's only going to make things more difficult down the road. Again, when I say take care of your health, take care of your feet health, you need to start thinking about doing that. So, Doc, I think we want to end up with one of the biggest ones that I know people deal with, which is going to be issues with your Achilles. And so Achilles tendonitis, which can be, again, an insult to an even further injury, which is an Achilles tendon tear, which by far one of the most difficult things to overcome, especially if you're performing an athlete. Doc, do you want to just break down the Achilles itself and what are some of the things that people will deal with when having this issue?
Yeah, so this is a tendon that goes to the heel, but it comes from some of the calf muscles, the gastrocnemius, the soleus, and that goes to a tendinous structure, like I said, to attach down to the heel. And over time, you might notice pain on the back of the heel. It could also be due to discomfort in the foot. It can have referred pain as well from there. People often see this and the pain with Achilles tendonitis through landing, so basketball players, that is also another one. It also can be from constant overuse of either not a proper gait formation. So like if, for example, if you put a lot of pressure on your heel and don't have a proper follow through or don't have the dorsiflexion, that's putting way more pressure on the Achilles tendon. Also going also back to what Doc said, if you are wearing heels, especially females, it's going to cause shortened contracture of the muscles of your calves, putting way more pressure and tension on the tendon, thus could also be pulling from the heel or calcaneus. It can lead to bone spurs, it can lead to other problems down the foot as well. Now there's some awesome literature, and this is where I found a lot of the research on how you can train tendons and ligaments differently than muscles, different than joints. It's through what's called the Alfredson's protocol. There's some research back in '98 to where Alfredson and his crew, his colleagues, noticed that if you slowly start lengthening this tendon, that it can ease up substantially on the pain and improve strength. And what I mean by lengthening, much the same before, if you are on your toes and then slowly lengthen your heel down to the ground, it forces more pulling tension on the calves and bleeds energy to the tendons of where those muscles attach to in the gastroc soleus, and also bleed into some of the tendinous structure right behind the knee. So not only for knee problems, but also for heel. So when you go into this, lengthening the area, you first want to start by ideally backing off on the activity that you're doing, whether it's basketball, whether it's sprinting, even cutting movements to a certain extent, depending on conditions in your knee, will also bleed energy and cause tendonitis in that tendon, the Achilles tendon. So as you're going to lengthening over time, let's say, okay, back off on that activity for maybe a few days, a week, and then slowly start in lengthening. Well, you can do this a couple different ways. If you have stairs at home, start on your toes and then slowly lengthen down as much as you possibly can. Spend a little bit of time at the bottom, and then you can go reset your feet up, whether that's both feet, come back up on your toes, stand on one foot then, and slowly lengthen down so you have more pressure and weight distribution of your body down through the Achilles tendon. And then over time you can add load. There's machines and gyms to where if you stand on a platform and there's a lot of pressure on your shoulders and you could load weight, you can then load it even more. Ideally for explosive movements, you have to have the proper gait mechanics of their foot, but a lot of it will come from the Achilles tendon for the heel strike down as you're trying to plant and go through. the gait cycle, running cycle. So lengthening of your heel down to the ground, lengthening of the muscles of your calves will help significantly for the repair and healing process. But that also gives us more insight for tendon structures throughout the whole body. If you lengthen them, much the same like we brought up with the lateral epicondylitis, it improves strength, it improves stabilization, decreases pain. That can be theorized through almost any other tissue of the body. Now you have to look at the different cell types that are in and around tissues, because like if you think about lengthening, okay, like, and we're going to get to the jaw here in upcoming series. If you lengthen tissues around the jaw, there's very limited studies on this, but those cells and those specific tissues are a different type of muscle structure, tendinous, ligamentous structure than it would be if it was in other parts of the body. So that's where we can start playing with different and theorizing with different rehab processes moving into the future.
But in most cases,
yes,
eccentric is going to win for
absolutely.
as far as type of exercise, right?
Yeah, that's going to bleed all the energy into that tendon instead of the muscle. Much of the same with isometrics for ligaments. And it's also hard to get blood flow to ligaments because they're just able to stabilize. And tendons are from muscle to bone. Ligaments are from bone to bone. It all depends on positions and how you want to train it and how everything kind of works together as a whole, from the foot to the knee to the leg. Much the same throughout the whole body. So,
and if you guys any of you work out, think of it like a backwards calf raise. Where
yes, good point.
you come up where you're trying to actually build mass and tissue. This is different. This is after you've raised, you're now slowly releasing the calf raise. But the reason why the stairs are a nice touch is because on a platform, you can only come down to where your feet stop on the platform. But on a staircase, you can actually come down below the plane and you can stretch your ankles up. So think of it as a calf raise where you can come down and actually now ankle flex above the plane where you would just stand on the platform. But yeah, think of it as just an eccentric calf raise, well, backwards calf raise, if you will, as a way to bleed energy, like Doc was saying.
Beautiful.
Yeah.
Cool.
So lastly, we have tools like we always do for improving each area. We ended on the foot, so let's start here. We'll work our way back up. Doc, let's do ankle foot workspace and just how people can stay ahead of the game with that.
Beautiful. So if you've been following the series thus far, we're going to move the ankle joint through the biggest range of motion possible, pain-free. That doesn't change. Even though the joints differ, we still want to work around the edges of the joint, and also it's going to bleed some of the energy into some of the ligaments, the muscles, some of the tendons on the edges that often don't get pressure against gravity or often don't have experienced load, if we will. So when we go through this, to isolate the ankle joint, ideally it can be work well seated. You can also do this standing, but you want to first start with whatever leg you want to work on. That same side arm, you're going to come underneath the knee. From there, the other hand is going to attach onto the shin bone. And then you can just lock your hand in place, or you can just hold it here. It doesn't matter. So we want to isolate the ankle joint. And what that's going to do, by holding this here, when we rotate, it's going to force less rotation in the knee and bleed all the energy into the ankle. So when we go through this, doesn't matter what direction you start with, clockwise, counterclockwise, you want to first go slow, nice, easy motion. This is going to be level 1, both directions, okay? Now, as we go into level 2, we want to move around that line of tightness. Now, this is very, very important. When you're going through, if you notice like quick little movements, you want to spend time in going back and forth between those. And you can even combine the ankle workspace with moving your toes or trying to point your toes out and down, because much the same like we said in the anatomy portion, a lot of the tissues of the feet start in the calves, and it's that juncture between those two. So if you combine those two together, even better. So as we go out, toes come outwards, we're trying to grip the ground, coming down, pointing the toes down, coming inwards. And for a lot of you, kind of the same thing with me. You want to go very, 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 very slow, pointing the toes up outwards. And you might notice popping, cracking. That's usually just tendons going over bone. As long as it's not painful, you're fine. If you notice sharp pain, or if there's other conditions going on, like let's say, there's pain on the outside, go just before that pain, go down, around, and then continue. Both directions. Over time, that area will shrink. But if it doesn't shrink, if there's still pain, sharpness, I would go see a medical provider, because there's other problems that can occur. But this is also awareness factor. It's an assessment protocol tool, and it's also a rehab for training the joints. As you're going through level 2, moving around that line of tightness for longer periods of time, after a couple weeks, you can add on weight or bands to the foot. Either that bands can be pulling and having pressure on the top of your foot outwards, the side of your foot outwards, the outside foot going inwards, or holding the band up to your chest so it's pulling in various different directions. Or you can also have a weight on your toes, which is, it's harder for you to point the toes, but it bleeds more energy to the ankle itself. There's variations.
Like a barbell, like a dumbbell, you mean?
Kind of.
Yeah,
yes,
yeah, yeah.
Very much similar. So that's one important tool that you'll have for the rest of your life for maintaining that structure. Now, as we go into the toes, especially the brain to body connection, I challenge you right now, if you are listening to this, can you lift your pinky toe up?
Ooh.
I mean, if you can't even just move that toe, you have a diminished signal to the area, and it will lead to other problems down the road. Either your feet are compressed, it can lead to other structural problems, plantar fasciitis. So that's just one step.
So by itself, or like all of them up at the same time?
Just try to lift your pinky or outside two toes.
So I can do it on this side, but I can't do it on this side.
So that's common. So like if you're right-footed, you're often going to notice your left foot being your plant foot, whether that's soccer, whether that's a bunch of different sports.
Yeah.
So that's often where the stabilization of those tissues don't have the fine motor skills or that connection of the nervous system down. Thus, you're not able to control the tissues.
Okay.
However, if you work on training your feet, you can move those in a bunch of different ways. You can move each toe in different from one another, which I can't do yet. But a good way that you can start off with this is, one, the assessment, but two, I highly suggest putting pressure of your big toe down to the ground and then lifting your outside four toes up. If it's hard for you to even do that, either hold that big toe down and then try to lift up the outside four toes. If it's hard for you to bend forward, hold a stick, hold your other foot, and then try to do the same thing, okay? From 5 to 10 seconds at a time. Okay, now we're gonna go opposite direction, because we want reps at this for more pressure and time to connect the nervous system to the tissues. Push your outside four toes down to the ground, lift your big toe up. Most people are gonna notice that when the big toe comes up, it's gonna come inwards due to compensation. That's okay. Over time, you want to make sure you just go straight upwards and then go back and forth. Big toe down, outside four toes up, foot down, big toe up, for reps until you either, one, if you notice cramping, that's fine, it's not a problem. You can back off and continue into work from there. Ideally, you want to work on that at least on a weekly basis, very minimally, to build up that connection. Once you have that connection, I would probably schedule it out maybe once every 3 weeks, once every month, and then build up from there. Another awesome tool is gripping the ground. So much like Doc said, if you have a pronated foot or if you have flat feet, there's going to be compensation to the inside of the knee, outside the hip, or various combinations thereof. You're trying to grip down to the ground and turn your feet inwards, which is going to strengthen and increase the tension on your medial arch, and that's how you can build up the arch. You can also do the same thing, put pressure of your feet down to the ground, and then try to turn your knee outwards, which will help for lateral movement, cutting, agility sports. But the big one is going to be gripping the ground and turning inwards, especially if you have plantar fasciitis. If you go to contraction relaxation for a period of time, that's going to work out and bleed more of the energy into the muscles, thus release the spasm that it has. Now, going back to the Alfredson's protocol, right? If we start with our feet contracted and then try to go on a tilted platform, or like let's say we're on a stairs, right? Try to grip the ground and then try to slowly lengthen. Bring your heel, back down to the ground as you're trying to grip the ground. That's going to bleed more energy to the tendinous structure, which is going from the plantar fascia to the heel, which oftentimes we see a lot of people have bone spurs from the heel to the plantar fascia. The bone necessarily can't be removed unless surgically operated, but unless it's really bad, risk versus reward, I would never suggest it.
No.
It's all where you bleed the muscle energy. So those are a few tools there. I guess, Doc, do you have any?
No, the only thing I want to bring up though is
Please.
why you have the bone spur on the bottom of your foot. So there's something called tenting, where what will happen is you have such a tight tissue, especially the fascia, plantar fascia on the bottom of the foot. It is so tight and it attaches to the heel that it's starting to actually create microfractures in and around where the tissue is pulling. Think of it as like an avulsion fracture in a way. So avulsion fractures where a ligament tears off a bone so hard it actually pulls the bone off. Now, what happens in plantar fascia, or just such a tight tissue area here with the bone spur, is it's so tight it can create microfractures, and what the bone then does, or what the body then does, is it fills in that little tented area of pulling with bone, and it just continues to tent and fill with bone. Tent, fill with bone. You now have a bone spur due to Wolff's Law, which is just force on an area over time builds bone. So this is actually what happens with a lot of bone spurs. When you start thinking about the areas that you get bone spurs, medial knee, right?
Yeah.
Behind the head, right? A lot of people that have a large EOP, external occipital protuberance. Again, over time we're seeing these areas form because of just a tension in that area. We talked about forward hedge posture a lot of the times. When we have that remodeling, it causes so much tension behind here, we see that spur formation. So the bone spur, a lot of the times people think, oh, I have arthritis and that's why the spur is there. It's like, no, it's not because you have arthritis. It was because you didn't catch the way that you were compensating for such a long period of time, and that's why you got it. So awareness, making sure that you're checking these things out. This is what's going to prevent a lot of these things. It wasn't that you were just genetically prone to getting arthritis, or diet, or just over time, whatever you think arthritis is due to. It was mostly caused due to poor biomechanics of the foot, and it easily could have been prevented had you, unfortunately, been educated or given this information earlier on in life. So, but yeah, I thought that was super interesting when I learned that.
The body adapts to forces over time, and Doc said it right there, Tenty. I actually just learned that process from you right now. Like, I knew that the bone spurs were accrued from stress over time, especially muscle tension, but I didn't understand that process.
Yeah.
So thank you.
It's crazy.
That's cool.
And when I learned that too, I was like, that makes so much sense, because what it did was it pushed me to create more effort to educate that, because a lot of the times I thought it was due to a mechanism at which I can't prevent or help with. Like bone spur formation, from what I originally had thought, was due to anything from past traumas, or again, poor diet, or there's just a lot of things that before I became a doctor, I didn't quite understand. And when I finally figured out Wolff's Law and just the understanding of stress on an area, like Doc said, that's what we were kind of taught, was stress on an area causes bone growth. It's like, okay, well, there's a lot of millions of things that could cause stress. But the actual understanding of poor biomechanics causing tenting, which then causes the spur. Spur comes after the fact. It wasn't spur causing pain. It was poor biomechanics causing spur causing pain.
Years and years of this.
Yes.
Yeah.
So
That's
definitely
good.
something that people should look for in assessing their feet and toes, making sure that they can keep that longevity of that area over time. So Doc, moving lastly into the hands and wrists and elbows, Let's start with elbows, go down to the wrist.
Perfect. So one of the best ways that we can work on the longevity of the elbow, I'll go into the workspace or the biggest circle we possibly can, but I think most people, especially if you're weightlifters and do bicep curls on a weekly basis, there's one small thing, well, there's a few things that you're missing with that. When you do a bicep curl, it's bleeding a lot of energy into this exact line of pulling tissue tension, if we will. So we're pretty much creating the forearm hand get closer or approximate to the shoulder. Now, when that happens, there's also different pulling muscles coming at angles and different angles on the sides. And now this principle is the same with any other tissue in the body. I'm just more or less having you focus on the muscle aspect. And the muscles, you can train those by going concentrically and eccentrically, or short and long, and then force the muscles to build up from there. If you have more questions on this, go to episode 2 on muscle building, tissue building. There's a lot of awesome information there. But going back to the elbows and how you can maintain those long term, especially if you notice boning of your arm outwards, or if you have tendonitis on the outside portion of the elbow. You want to start off by, and you can start off wherever in the cycle, but ideally I like people starting off arm completely straight, trying to turn the palm or hand outwards, and then go nice and easy, level 1, nice, easy, full range of motion, keeping your palm facing your shoulder. As it's shortened, turn your palm outwards and then lengthen from there. You can rotate and go through a circle that way. You can also go the opposite way. Start palm facing downwards, arm completely straight, turn and go back around. Okay, complete opposite direction. Now, level 2 is moving through that line of tightness, and this is where it can help with any types of tendonitis. If you notice more pressure or tension, or it feels like a good stress on the area, spending more time where it feels that stress. And then again, it's the assessment tool and also a tool that can help for trained joints. So what we then want to do is then go try to turn your palm facing outwards. It might cause you to shake a little bit. That's perfectly fine. Making sure your arm is straight so all the energy is going through the elbow. As much as you possibly can, turn the arm outwards. Try not to flare your elbow outwards, so if you have to hold underneath, and then try to roll your palm facing down. Slow, opposite direction, same thing. And then level 3, this is where bicep curls come in. So if we're doing bicep curls or hammer curls, that's awesome, but that's only bleeding energy to a few different areas of the tendons. There's also muscles on the outside, inside portion of the arm that will often get neglected, which leads to elbow problems, which can also replicate if you do benching for a period of time. Depending on where your elbows are, it's going to bleed more energy to either inside or outside, depending on grip arm placement. So going back to the bicep curl, if you have a weight in your hand, again, go through, maybe start off with extension of the wrist, turn your palm facing outwards as you come up as much as you can. Turn. If you have a much larger weight, which you don't need a large weight, you just need time under intensity, you can also go either diminish it, turn, and then come down, and then slowly, as you're holding the weight, come downwards, the opposite direction. Now, when you go the opposite direction with weight, again, huge key focus, you're not rolling your elbow outwards. So hold underneath, come down, and then back around. So level 1 through 3, we're bleeding all the energy to the edges of the joints, which will help build up that joint capsule, especially radial head that can have a lot of pressure on the outside portion of the arm. And over time, as you come back down, again, we can go to eccentrics for lateral epicondylitis. That tool can help with so many other conditions of the whole arm itself. Now, there's another one that I want to go into for the hands and the wrists. I know we touched on it. If you have tight wrist flexors, if you notice your hand comes forward and you have carpal tunnel syndrome or pain in the front of the wrist. I know we touched on going to extension with light muscle contraction or trying to grip to the ground. Now you can do this a few different ways. If you're an office worker, I usually have people combine the whole arm torso together, if we will, because I mean, unless you're individualizing and have the time to individualize a rehab for not only just the hands and wrists, ideally you might as well spend time throughout the whole upper body. So there's a few one I like to bring up. This is called the Brugger's relief technique. It's where you bring your shoulder blades together and down. You hold your palms facing upwards. Ideally, you want to rotate your palms out, extend your wrists, and you want to hold and squeeze all these muscles, ideally lighter muscle contraction for a minute at a time. If you can do 2 minutes, beautiful. Set a reminder on your phone, especially if you are on a computer for a period of time, or another way you can go about it if you're on a computer. If you look at a sticker and every time you look at that sticker, okay, shoot, let's take a break. Let's go hold this position for periods of time. It forces more strengthening in your wrist extensors. You can also do wrist extension as well for reps, or hold your weight in your hand as everything's contracted, your wrist flexors, and then slowly go down, which bleeds energy to the tendinous structures around the carpal tunnel or the front of the wrist. That will also ease up that tension as well. But ideally, wrist strengthening, bring everything externally rotated, where most of the time our bodies are coming back to center in front of us. We're gonna go the complete opposite way, which is why that technique works really well for desk workers. So I think those are a few awesome protocols that can be utilized throughout the whole body. There's also an area or a way that you can increase the tension of your wrist by connecting a rubber band around your fingers and then bring and open up for reps as well. But there's a bunch of different ways. If you YouTube rehab for specific structure, you're gonna get a lot of answers, but understanding what is going on so you can maintain your structure long-term, that's the most important thing.
Absolutely. And I bet you, even just the elbow one, so many of that have elbow pain. I bet you that 1 through 3 level, if you were to just do that every day, I bet you that alone could take care of a lot of that elbow pain that you're having.
It already increased range of motion,
yes,
regardless.
This is for longevity of the joint, but what you don't realize is those are the exercises that you could be doing anyway if you have pain. So
pain or not.
Yeah.
Yes.
So when you started hitting on that, I'm like, oh yeah, that's super cool. But there was a lot of gems today. Now that I go back and I think about everything we talked about, we really touched on a lot of intricacies of each of these areas. And so you might want to watch this again and really just make sure that you hit on the things that we were stating. And it might take a few times to really capture what we were saying. And if there's ways that you want us to break it down even further, please let us know. We can do that with short form content for you, because again, we really do. When you go back and listen to it, I know that you're going to get a lot of information. These podcasts are quite lengthy, but we hit a lot today, and these were multiple areas of the body versus just one area that we've kind of been doing with this series. So please let us know in the comments what you'd like us to break down even further. Go ahead and rewatch this again if you have any of these issues. There was a really good amount of content today, I think, that me and Doc went on. So thank you guys so much again for watching. This is the end of today's podcast. Please like, subscribe, and share. And again, thank you guys for everything that you guys do. We appreciate you guys so much, and we look forward to seeing you guys in the next podcast. Woo! God, that was great.
Man,
I didn't think that one was going to be that great.
Thanks for joining us on The Functional Code. For more evidence-based health insights, subscribe, rate and review wherever you get your podcasts. Remember, your journey to a healthier you begins with understanding the functional code. Until next time, stay well, stay informed, and embrace the science of living well.